Yeah, this is a wonderful question. We have the paradigm study, which was presented as part of the plenary session at ASH 2025. And the studies indicated that patients who got azacitidine in combination with venetoclax, superior overall response rates and high complete CR rates compared to chemotherapy. However, the CR rates were not different. And the study did reach its primary endpoint of event-free survival, which was again superior in the aza-ven group versus the intensive chemo arm. So what this really translates into is that patients with adverse risk features, I think, if they are eligible to get intensive chemo, but if we are concerned that the patient has adverse risk features, we do have the paradigm study to back up our management and go with aza-ven instead. And we have also seen, better quality of life, better financial, less financial burden with the aza-ven combination compared to intensive chemotherapy. And lastly, the number of patients who could also went to transplant was noted to be higher with aza-ven. So overall, I think it's a really good option that we have. It may not necessarily completely take away the importance of intensive chemo, I think, but I certainly think that it's a valid option. Right now, the landscape of menin inhibitors is, growing rapidly. We already have 2 drugs, revumenib and ziftomenib, that have been approved by the FDA in KMT2A and NPM1 and NPM1-mutated AML. And ziftomenib is also a great drug. It's a novel agent. And one thing is that it has a very wide therapeutic index. It doesn't cause, there is not much of drug accumulation. And with and without the azoles, the half-life is very comparable. So I think it's a great option where we worry about the adding azoles to our patients. And the safety profile, I think, is also really good in terms of differentiation and QTC prolongation. It was, I would say, a little bit better than what has been reported with other menin inhibitors. The differentiation syndrome is around 12% and around 9% of QTC prolongation. In terms of efficacy, I would say, in the KMT2A, the responses are really good, about 70% CRC rate. The dose optimization for the NPM1-mutated is still ongoing, so we learn more. But overall, I think the results are very encouraging in terms of efficacy as well. So many menin inhibitors now being approved, or at least in advanced stages of development. I personally feel it's going to be very much like CML, where, we have different TKIs and we try to see what comorbidities the patient may have and what would be the best drug in that sense. So yes, in patients with, issues with heart rhythm, arrhythmias, revumenib may be a little bit more concerning to be used because of possible toxicity with QTC prolongation compared to ziftomenib, even though ziftomenib can also cause QTC prolongation, but it's not a boxed warning. So in that sense, yes, somebody might prefer to choose one over the other. Compliance is important too. Ziftomenib is once a day versus revumenib. So if a patient cannot deal with twice a day dosing of a drug, I think for that patient, zifto might be a better option. But I think in terms of efficacy, the medications are very comparable. Even in terms of their side effects, I think it's comparable. Aza-ven in the YLEA study showed especially, high responses in the NPM1-mutated patients and the IDH-mutated patients. But with adding on the ziftomenib, the responses are even more robust, and they're higher and they are durable responses. So I think this is definitely a game changer. And in particular, the MRD negativity rate for the PCR is also pretty significantly better with the triple combo versus aza-ven alone.